Talk about the mandible as a key structure. What are the unique features of this mandible bone? It is the largest bone in the human skull. It holds the lower teeth in place. It assists in mastication and forms the lower jawline. Other than the ossicles of the ear, the mandible is the only skull bone that is mobile, allowing the bone to contribute to mastication. So we'll discuss the history. In the past, it was standard practice to resect the mandible as a part of excision of many. In the past, it was standard practice to resect the mandible as part of excision of many intraoral cancers. Initially, it was thought necessary for adequate tumor clearance. A pioneer, Panagopoulos, in 1959, found mandibular involvement in 12 out of 48 cases and proposed that the bone involvement in oromaxillary tumors occur by extension of neoplasm through nutrient canals or either by Volkmann canal in few cases. Later on, despite the histological proof, many of the mandibles sacrificed were uninvolved. So segmental and hemi mandibulectomy remained the mainstay of surgical treatment for oral cancers adjacent to mandible because it provided the excellent exposure and easy closure of the surgical defect. The functional and cosmetic results associated are devastating to the patients due to impairment of occlusion, mandibular deviation, overall decreased range of motion, temporomandibular joint pain, poor contour of the symphysis, diet restriction restricted only to the soft foods. With improvement and advances in the imaging as well as reconstruction techniques, the balance has swung in favor of mandible sparing surgeries where the results are cosmetically and functionally superior. So now we'll discuss the mechanism of mandibular invasion. Carcinoma of mandibular region is defined as a carcinoma arising from either from the mandibular alveolar ridge or from the buccal sulcus, lower buccal sulcus, or the lower sublingual sulcus, or the mandibular retromolar trigone. It had long been assumed that oral squamous cell carcinoma had the potential to spread either via lymphatics within the mandibular lingual periosteum. So we have, I am going to discuss about the two patterns of mandibular involvement, that are the erosive type and the infiltrative type. So first one is erosive type. This is the erosive pattern. In this erosive pattern, the tumor advances on broad front with the connective tissue layer and active osteoclast separates the tumor from the bone. Histologically, it is marked by broad, sharp, pushing tumor front with the distinct absence of bone islands within the main tumor mass. There is increased osteoclastic activity in the erosive pattern of disease. Further evidence that there is progression from the erosive to the invasive pattern as the extent of the tumor invasion of the mandibular increases. So now we'll discuss about the infiltrative pattern. It is the diffuse one with irregular destruction of the bone, and it spreads into the cancellous bone. The infiltrative pattern is characterized by an irregular tumor front with the nest of the tumor cells and bone islands left within the main tumor mass. In infiltrative pattern, it was difficult to determine the resection margins antero-posteriorly because bony invasion by the tumor cell spreading transmedullary is not radiologically identifiable. So a more aggressive behavior with an increased likelihood of positive margins, recurrence, death with disease, and shorter disease-free survival was seen. A 3-year disease-free survival was seen in 30% for the infiltrative pattern, whereas in erosive it was 73%. So in a study, a total 25 consecutive patients who had undergone mandibular resection, infiltrative in 14 and erosive in 11 was seen. It was cortical in 5, marrow involvement in 15, while 5 had spread through the inferior alveolar canal. It was found that a high incidence of spread 20% through the canal of the inferior alveolar nerve, which often exclude the preservation of the mandible. In these cases, it is often very difficult to access the involvement of the mandible preoperatively, and subsequent conservation of mandible can
ये
lead
देखो
to
दांत टूटे हुए हैं आने के देखो सबके दांत टूटे हुए हैं दांत है.
In these cases, it is often very difficult to access the involvement of mandible preoperatively, and subsequent conservation of the mandible can lead to positive resection margins if the canal has not been excised. As a result, it suggests that careful preoperative examination of the mandible is required to rule out the bone invasion. It shows that spread through the canal of the inferior alveolar nerve or the nerve itself may be cause of increased rate of local recurrence seen after the mandibular conservation surgery. Roots of the tumor invasion. Carcinoma travels along the surface mucosa and submucosal soft tissues until it approaches the attached gingiva, where tumor cells may come in contact with the periosteum of the mandible. In dentate patients, tumor cells were thought to migrate through the PDL spaces, whereas in edentulous patient, it was going through the occlusal surfaces of the alveolus and enter into the mandible. Less commonly, mental and mandibular canals or the lower border of the mandible, which can be invaded by direct spread from cervical lymph nodes. So, composite resection of the oral cancer with en bloc resection of the segment or hemimandible with neck dissection was the mainstay of the treatment to allow the complete extirpation of the tumor. In 1971, Marchetta first challenged the concept of periosteal lymphatics for mandibular invasion and attempted the first mandibular conservation procedure if there is clinically normal tissue intervening between the bone and the tumor. McGregor and McDonald et al. Reported that inferior alveolar nerve could also be invaded and therefore should be resected along with the mandibular canal during the marginal mandibulectomy. Brown et al. Reported that tumors enter the mandible at the point of abutment, which is related to the site of primary tumor. Now we'll come to the preoperative assessment. Clinical examination and imaging, along with the understanding of the pattern of the roots and routes of invasion, is essential in deciding the appropriate level and extent of mandibular resection in oral squamous cell carcinoma. Clinical assessment of mandibular invasion is performed by bimanually assessing the mobility of the tumor mass in relation to the mandible or fixity of the tumor to the mandible. Careful clinical and radiological correlation is required to achieve the ultimate goal for not sacrificing any more bone that need to remove the entire tumor. Marginal mandibulectomy is an oncologically safe procedure to achieve good local control which provides a better quality of prediction of mandibular involvement clinically. We can clinically predict it by manually examination of the mandible by of the tumor mass in relation to the mandible or fixity of the tumor to the mandible. Inspection and palpation includes the cortical thickening. Symptoms of inferior alveolar nerve paresthesia will ask the patient, and bony irregularities will touch bimanually by manual palpation, by palpation of our fingers, and pathological fractures by moving the segments by our index finger and thumb if they are present in the mandible. In the presence of trismus due to submucous fibrosis, which is related to either tobacco or betel nut chewing, or due to pterygoid or masseter muscle involvement, that precludes the bimanual palpation of the mandible to detect supple cortical invasion. So radiographically, how we will predict the mandibular involvement? There is no single imaging technique that tells 100% reliability. So from the treatment perspective, it is crucial to determine the bone involvement caused by these tumors, and due to the underestimation, it may lead to a partial resection, resulting in local recurrence and potential metastasis. Surgeons are often inclined to perform the segmental resection to avoid the undertreatment. Careful correlation of the clinical as well as the imaging finding is very important to assess the mandibular invasion and setting the bony margins of resection. Radiographically, plain films, orthotomograms, computerized tomography, or magnetic resonance imaging and bone scans have been used with varying degree of accuracy. So first we'll talk about the OPG or tomogram. It plays an important role in detection of the bone involvement in determining the supero-inferior extent of the tumor in the bone and is therefore helpful in planning the surgical procedure. Nakayama et al. In 1999 advocated the use of this study. Hong et al. In 2001 deciding the required anteroposterior limits of the resection. Among the different kinds of imaging modalities, intraoral periapical films were also used with paralleling technique which seems to provide the most valuable information due to their fine anatomical detail. But it was not at all so much of advantageous because it does not tell us if the mineral loss is less than 30%. Mandibular invasion in squamous cell carcinoma investigatory by clinical as well as orthomopentomogram. A prospective open study of 51 patients undergoing mandibular resection for oral squamous cell carcinoma were examined to uh, to examine the incidence of mandibular bone invasion and to assess the predictive capabilities of clinical and radiographical examination in detecting the bone involvement. After resection, the mandible was sectioned serially at every centimeter to find the pathological bone involvement. Specimens from 25 patients, 4 were segmental and 21 were hemimandibulectomy patients, demonstrated tumor invasion and histological examination. Clinical impression of mandibular invasion shows a sensitivity of 96% and specificity of 65%, whereas radiological examination has sensitivity of 92% and specificity of 88%. When considered together, clinical as well as the radiological examination, the specificity was only 58%. This study advocates a careful correlation with the clinical as well as the radiological findings prior to definitive therapy, as clinical examination tend to overdiagnose the bone invasion in tumor adjacent to the mandible. This study was undertaken in an effort to allow the head and neck surgeon to make informed decisions regarding mandibular sacrifice. Clinical examination and OPGs were found sensitive enough to use the primary investigative modalities. But both tend to overpredict the extent of invasion, resulting in unnecessary loss of the mandible sometimes. The high false positive rates associated with these basic investigative modalities advocated the use of more sophisticated tools like CT scans, MRIs, or bone scintigraphies. So we'll move on to the CT scan, computerized tomography. It is the standard technique for staging malignant tumors of the head and neck region in terms of its size, location, spread in the bone, as well as in the soft tissue, and the regional lymph node involvement was seen in CT scan. With the axial and the coronal cuts, we can justify the angle of the ramus tumor spread. The cone beam and DENTA scan have shown promising results in identification of mandibular invasion by oral squamous cell carcinoma. In MRI is superior to CT scan as it detects early soft tissue and medullary involvement and not affected by metal artifacts, whereas in CT it is affected by metal artifacts. However, it is less reliable in evaluation of cortical bone involvement because of lack of signal from cortex secondary to its low number of mobile hydrogen ions. Zumi et al. In 2006 reported low specificity of MRI scan to detect the mandibular cortical invasion and inferior canal involvement. False positive results were obtained in MRI because if surrounding inflammation of the bone is seen, it will lead to the overestimation of the tumor extent. So we'll come to the bone scintigraphy. Bone scintigraphy is generally considered as the most reliable method to detect the bone invasion and distant metastasis. Increased bone turnover in squamous cell carcinoma gives rise to hotspots on the bone scan, thus detecting even the periosteal involvement too in bone scintigraphy. Several studies have reported on high sensitivity and low specificity of bone scans. Prediction of mandibular involvement radiographically. Trimming et al. 2000 reported 100% sensitivity and 91.6% specificity for computer-aided technetium dicarboxypropane single photon emission CT and another one was conventional. One is computer-aided and another one is conventional. These modalities with clinical examination, panoramic radiography and CT were used in assessment of mandibular bone involvement by squamous cell carcinoma in 50 number of cases. Babin et al. In 2008 reported the fusing of positron emission tomography with CT to maximize the data information. Positron emission tomography shows the sensitivity of 100% with specificity of 85%. Then Ken et al. In 2008 reported combinations of CT and SPECT or MRI and SPECT to predict the mandibular invasion without yielding false negative results. Panorex and intraoral radiographs carry the disadvantage of not detecting the mandibular if it is less than 30% mineral loss. McGregor and McDonald in 1988 advocated the clinical assessment of mandibular invasion by lifting the periosteum at the time of surgery. Pandey sir et al. In 2009 too have reported on the findings on periosteal stripping, namely subperiosteal reaction, cortical expansion, presence of pathological fracture as significant predictors of bone invasion. Forrest et al. In 1995 advocated the frozen section analysis of cancellous bone to confirm the adequacy of bony margins. Weisbluth et al. In 2010 assessed the effectiveness of intraoperatively frozen section analysis of trephine drilled bone specimens and found 94% consistency between the frozen section analysis and histopathological examination of decalcified bone with the sensitivity of 79 and specificity of 98%. So we have two mandibular approaches. One is segmental and another one is mandibulotomy, marginal mandibulectomy, segmental or mandibulotomy. So we'll talk about the marginal mandibulectomy, which was described by Kreil in 1923 as an incision that is carried down underlying the bone, thence into the bone by the sharp chisel or the saw, so that a slice of the bone can be split off into a piece bearing the undisturbed cancer off as a bone platter. Contemporary marginal mandibulectomy usually refers to the resections of either the inner table or the alveolar ridge of the mandibles. Indications were marginal mandibulectomy has been used in the cases where the tumor abuts the mandible or is adherent to the periosteum or where the resection of the alveolar process is necessary to obtain the third dimension of the deep surface of the tumor. Now we'll talk about the segmental or the hemimandibulectomy. It remained the mainstay of the surgical treatment for oral cancers adjacent to the mandible because it provided the excellent exposure and easy closure to the surgical defects. Segmental mandibular defects remain of functional as well as the cosmetically difficulty for the patients with head and neck cancers. Carcinomas of RMT and advanced tumors of the adjacent tonsillar fossa have historically been treated with posterior segmental mandibulectomy. In advanced stages, required a radical operation with segmental mandibulectomy. However, the loco-regional recurrence rate was high. Various studies in marginal mandibulectomy were Shaha et al. In 1984 used the marginal mandibulectomy for treatment of smaller floor of mouth malignancy and segmental for large tumors. Randall recommended the marginal mandibulectomy when there was no radiographic evidence of bone lesion and less than 50% of the circumference was involved by the tumor. Totsuka in 1991 regarding the mandibular gingival carcinoma showed almost the same survival of 2-year follow-up after the marginal technique 86% and segmental technique in 82%. Byers et al. In 1984 reported local recurrence of 7% in their series and 110 patients with various forms of mandibulectomy with or without coronoidectomy for RMT cancers. It is continued. Collins and Saunders describe the intraoral marginal mandibulectomy in 2 of 8 number of patients which were treated conservative mandibulectomy for oral cavity cancers which were adjacent to or clinically just were attached to the mandibular periosteum without clear radiographical evidence of bone destruction. The intraoral defects in both of these patients were closed primarily and both patients had normal recovery for speech and swallowing. Shaha in 1992 reported whenever the tumor is close to the mandible or adherent to the periosteum, consideration should be given to marginal mandibulectomy. In 65 number of patients that the author reported, 22 underwent marginal, whereas most of the patients had oblique mandibulectomy including the resection of upper rim 2 and medial cortex of the mandible also. Pinsol et al. In 1997 did posterior marginal mandiblectomy in 40 number of patients with tumors of the oral cavity and oropharynx without preoperative radiographic evidence of bone erosion. These authors reported no complications associated with the mandibulectomy and good maintenance of cosmesis. Prognosis in cases with the mandibular invasion. The prognostic impact of the mandibular invasion by oral squamous cell carcinoma is controversial. There have been reports of decreased survival rates and increased recurrence with the bone invasion and survival rates independent of bone invasion. O'Brien et al. In 2003 reported a series of 94 patients who underwent marginal resection and 33 underwent segmental resection. Among these patients with the bone invasion, the local control rate was higher as following the segmental resection when compared to the marginal resection. It was 87% versus 75%, but this was not statistically significant. Survival was significantly influenced by positive soft tissue margins, but not bone invasion or the type of resection. This reported tumor stage, margin of surgical excision, nodal stage as predictors of survival in their study of 51 number of patients with squamous cell carcinoma of mandibular region. They found no significant difference in survival between the patients with pathologically positive mandible with those not having mandibular involvement, and concluded that mandibular conservation might be carried out even in the presence of involved mandible if negative resection margins could be achieved. So now we'll talk about the mandibular reconstruction. Mandibular reconstruction is a challenging for most head and neck surgeons. So based on the new advances, we have gone on the concepts of computer-aided design as well as the virtual surgical planning. The main disadvantage of these techniques are these techniques lack the flexibility, especially in the oncology. The currently available primary options for mandibular reconstruction are plate with or without soft tissue flaps and bony grafts as well as the free flaps. The latter is suitable for small bony grafts or mandibular osteocutaneous free flaps. Currently, fibular osteocutaneous free flap is considered the gold standard for reconstruction of the mandibular defect, while the elytrus is considered as the better option for mandibular angle defects, body defects, or defects with requiring greater soft tissue bulk for intraoral lining. So these are the we'll talk about the recent advances, that is computerized tomography, the computer-aided design, the virtual signal planning, which enable to create the 3D model, stereolithographic model to pre-bend the reconstruction plate and obtain the landmarks for osteotomy. A custom-made pre-bend plate is obtained to guide the osteotomy lines and to achieve the correct positioning of the resected bone. The shaped fistula is superimposed onto the mandibular defect, and the contour of the fibula is as similar as possible to estimated shape of the native mandible. So, computer-aided mandibular reconstruction was introduced with the development of computer-aided device design and additive manufacturing technologies. Computer-aided design reconstruction facilitates facial surgery using stereolithographic models, cutting guides, surgical templates, pre-bend, or patient-specific plates were used. What were the drawbacks? Operative margins closely follow those anticipated by the surgical team in the preoperative planning phase based on imaging. Expense, because of the expense involved in the terms of the cost and time for the preoperative planning and for producing the single-use cutting guides and plates. So because of these two, these are the drawbacks in computer-aided design. What are the benefits? That it saves the time during the surgery and eventual reduction in the hospital stay of the patient. So goals of the mandibular reconstruction. What are the goals? To restore the shape of the lower third of the face and enhance the functional stability, functional ability in terms of chewing, swallowing, speaking. So here we'll talk about for mandibular reconstruction, we will talk about the osteomyocutaneous free flap for the reconstruction of the oromandibular defect. First of all, what are the uses? That it is reliable, it is functionally acceptable, it is cosmetically acceptable as well. resembles the mandible in terms of the width, length, and thickness, should have sufficient bone for dental implant placement for dental rehabilitation. It should be having minimal donor site morbidity. Least complication should be there. It should be easy to harvest with high survival rate and low donor site morbidity. So what are the reconstructive options for mandibular defect? So first is osteocutaneous fibular flap. Another one is scapula flap. Another one, third one is iliac flap. Fourth one is the radial forearm flap. Fifth one is vascularized rib with bone supply from the latissimus dorsi muscle. Vascularized median femoral condyle cortico-periosteal flap for shorter defects. Reconstructive plates covered with the myocutaneous flap. It can be any myocutaneous flap, either radial or scapular or any thigh flap or any myocutaneous flap. And delayed repair with the non-vascularized bone graft. So first we'll talk about the free fibular flap. Free fibular flap is optimal for subtotal as well as for total mandibulectomy, requiring the long bone segments for reconstruction based on the which is based on the peroneal artery and vena comitans. This is the pedicle of the free flap, fibula free flap. Fibula free flap allows a large amount of bone stock, that is around 22 to 26 centimeters with that dense cortical bone, which is used for oral rehabilitation. The pedicle size is also 2 to 3 mm in dia and 15 centimeter in length. So we get an adequate length to anastomosis and kinking of the pedicle is less. Along with the reliable skin pedicle, that is 20 to 25 centimeter to 10 to 14 centimeter in length, needed to reconstruct the intraoral as well as the extraoral defects with low donor site morbidity. Free fibula flap has the better clinical as well as the aesthetic as well as the functional outcome as observed when endosseous implants were incorporated into the fibula free flap. One of the main challenge in performing the fibula free flap is contouring the linear bone to match the resected curve-shaped mandible. So we have to just osteotomize it into many segments, either into 3 segments or into multiple segments, and this can lead to our pedicle rupture. As we can see in this diagram, this is the peroneal vessel. This is the harvested bone that we can harvest. The length is 22 to 26 centimeter. 6 centimeter we used to leave upper and the lower segment. Skin is taken as well as subcutaneous tissue is taken, bone is taken as well as muscle is also taken. So innovation to overcome the lack of flexibility in planned mandibular reconstruction, the development of semi-standardized mandible and fibula resection cutting guide were used universally and adapted to different patients during the surgery. This technique was first developed by Department of Oral Maxillofacial Surgery of Munich University in 2018. They used a computerized tomography to analyze the different parameters in the patients who underwent the mandibular reconstruction. So here is the mandibular recon guide. It is a universal reusable resection guide that is used for mandibular reconstruction with the fibula free flap. It is generally used for right and the left mandibular body as well as for the symphysis region also. This center segment fits into the symphysis region and this left and the right portion are for the body of the mandible. It has 2 cutting guides, including one each for the fibula and the mandible, which are connected and coordinated through the specific color code and the numbers. The green refers to the right side of the guide and blue refers to the left side of the guide. The number allows the user to arrange the guide segments into the correct sequence. Both cutting guides have the sliding bar to adjust the length of the lateral segment. This is adjustable, like we can adjust. This can go inside and this can come inside. From here, we can adjust the lateral segment, bony cuts. The aforementioned features allow the resected fibula to fit into the mandible with the correct angulation. So these are the some surgical steps that we use This is the recon guide that we have placed it in the lower border of the mandible. This is kept in the symphysis region, and this is the lateral part of the body. So according to the extension, we used to keep it in the oral cavity. We used to expose it, but this has been exposed by the visor flap, and this lower border of the mandible has been exposed. And after fixing the cutting guide on the inferior edge of the mandible, the length was marked, and this value was passed on to the reconstruction team. In the step 3, what we did, the same length is set on the osteotomy template also, fixed on the fibula to permit the flap to be raised. Here we didn't cut the pedicles yet. So we have just osteotomies have been made, and when the osteotomies have been made, osteosynthesis and mini plants enable the graft fixation before the flap ischemia, for which the guide is still in place. And when the graft has been primarily fixated using the anterior plates, right and the left, here we used to plate right and the left, and 2 mini plates are attached later to achieve the adequate stability. In the step 6, the vascular pedicle was cut and finally transected, and fibular graft can be placed and secured in the mandible. And again here plating was done. Like this is the fibular part, and this is the rest of the mandible part, and plating was done. Final plating was done. This was the step 7. So what are the advantages? It provides us a length of 26 mm in adults, with the 26 centimeters, in adults, and skin pedicle of length 25 centimeter and 5 centimeter in mm, 25 mm and 5 mm in width. So, concurrent harvesting with the 2 surgical teams with the distant donor and recipient sites. Supine position of the patient is required. Easy reconstruction of the mandible is achieved by the free fibula graft. Excellent results in the terms of functional as well as the aesthetics. Mild donor site sequel due to stability. 4 centimeter distal fibula is preserved because 4 centimeter of distal instability. Matlab, from the donor side, we used to leave 4 centimeter or 6 centimeter bone at the upper as well as at the lower end. So this leads to the stability of the foot. Matlab, this did not cause any instability, and it is very much helpful in children where growth retardation does not happen in the leg. Well-defined vascular supply, even if we do the multiple osteotomies. Anastomosis to the large vessels in the head and neck, artery having 1.5 to 2.5 mm of length, and vein having the 2 to 4 mm. So advantages, it is triangular in cross section with a high density of the cortical bone. That is very much helpful for placing the implants. It raises the angular as well as the rotational stresses that occurs when the masticatory forces on the mandible occurs. So it relies that it does not help in the angular as well as the rotational movements of the mandible. It reduction in the surgery time, because sometimes we used to do the fibular flap as well as the implant placement together at the same time. So it reduces the surgical time. The correct positioning of the resected bone. The bone used to be resected, and correct positioning of the bone is achieved with the proper contour of the mandible, with the proper maxillomandibular hard tissue as well as the soft tissue, what do we call it? But there is no class 3 or class 2 defects seen in the side profile of the patients. Fibular reduction and osteosynthesis can safely and easily performed under the stable conditions with the pedicle pumping without any assistance. The angle of bony contact between the remaining jaw and the free fibular flap are perfectly matched, clearly improving the integration of the flap. What are the disadvantages? Due to multiple osteotomies, there is chances of destruction of centromedullary fibular pedicle, or there might be pedicle kinking also. Aesthetic sequelae is there, suitable in the patient with the ischemic disease or the lower limb problems, or sometimes short length of the pedicle is seen. In fibula, we usually get a small pedicle, whereas in scapular flap, we usually get a long length of the pedicle. Skin pedal inadequacy in large soft tissue reconstruction. If the defect is more than half of the mandible, hemimandibulectomy has been done, and more than half of the mandible, it has to be reconstructed. It can be reconstructed with the free fibular flap. Uh, uh, restrict restriction of the motion of the donor side. In the donor side, sometimes patient complaint of the pain of the foot, and sometimes ankles instability is there. And there are so many, matlab, donor side disadvantages and recipient side disadvantages are there. Donor side, it includes like edema or pain or impaired ambulation, or sometimes dehiscence of the wound, or sometimes if we used to place the skin graft, sometimes it used to matlab, our body didn't uptake don't uptake, so because the skin graft loss, also bone and the tendon exposure sometimes happens due to the foot drop. These are sometimes some of the donor side what do we call it? Donor side complications. And if we'll talk about the recipient side, sometimes arterial insufficiency or venous congestion, hemorrhage, hematoma, or skin island necrosis might can be seen. Infection, yeah, plate fracture, these and all, or non-union of the bone, or osteoradionecrosis. Usually, we used to see in this tree flap. So some more of the drawbacks are that that recon guide that we use, it costs very high. Large time requirements for planning and implementation of the tailor-made devices for individual patients. Absolute lack of flexibility in the planned surgery, in which malignant tumors secondarily involve or originate from the mandible and potentially require a surgical adaptation. For the tumors with extensive soft paramandibular tissue involvement, the application of the resection template might be difficult or even impossible, because it needs to be in close contact with the bare external and inferior cortical bone. The device is usable for symphysis, but not for the ramus. Only for symphysis as well as for the body region, but not for the ramus region. That reconstruction guide that we talked about, that is not for the ramus region. Scapular flap is based on the subscapular artery that arises from the distal border of the subscapularis muscle from the third portion on the axillary artery. It measures 2 to 4 mm in diameter, that is totally suitable for head and neck reconstruction. Venous is vena comitans. So we usually take either the medial osseous flap or we take the lateral osseous flap. So if we take the medial osseous flap, the osseous segment from the medial border of the scapula, it usually measures about 10 to 12 centimeter into 3 centimeter into 0.71 to 1.5 centimeter in depth, and through its facial attachments to the bone. So this is the lateral osseous flap. The length, these are of three types. Lateral osseous flap, which is based on the periosteal branches of the circumflex scapular artery. In the picture B, we can see the extended lateral osseous flap, which include the tip of the scapula too, where both of the periosteal branches as well as the circumflex scapular artery branches and the angular artery are preserved. And third one is the tip of the scapula osseous flap based on the angular artery only. So these are the three kind of the lateral osseous flap. The length and the length of the lateral osseous bone that can be reliably elevated on the periosteal branches of circumflex circumflex scapular artery depends on number of planned osteotomies. Usually it gives up to 10 centimeter in women, 14 centimeter in men. The bone can be up to 3 centimeter wide with variable thickness. It can from there say 1.5 to 3 centimeter along the length of the flap. If more distal osteotomies or longer bone is needed, the scapular tip, an additional 3 to 4 centimeter of the bone can be safely and simultaneously harvested based on the angular artery. The tip of the scapula can be harvested as a separate vascularized bone graft. So these are some anatomic variations that we see in scapular artery. Sometimes we used to see the double circumflex scapular artery in 8 to 14% of cases. Sometimes we see the double vein also in 14 number of patients. Sometimes this circumflex scapular artery originating separately from the axillary artery in 4 to 8% of the patients, and the vein separates from the axillary vein in 12% of the patients. So these are some of the variations in scapular. So what are the indications? It generally, because of its contour, because of its contour, like it is a C-shaped bone, it is indicated in anterior, sagittal, and hemimandibular defects, which can be restored with the osteocutaneous osteocutaneous scapular flaps. Composite defects of the mandible with large soft tissue requirement for intraoral lining, external coverage, and for soft tissue augmentation. It is indicated in that also. In because scapular flap has a fibula is not available due to if fibula is not available due to vascular disease, so it can be used. Patient who does not want who wants to avoid the morbidity of the vascularized iliac crest flap, so this scapular flap is indicated. It is contraindicated in the osseous defects larger than 14 centimeters in men and 10 centimeter in women. Need for multiple osteotomy, which can lead to the viability, which can lead to endangered viability of the osseous flap. Pre-existing shoulder disorders limiting range of the motion, and periscapular muscle strength. These are the contraindications. So damage to the vascular flap due to injury or the procedure, example lymphadenectomy, and skin of the back is too thick in obese patients. So these are some contraindications where scapular flap is not used. So now we'll talk about the advantages of the scapular flap. The hairless nature of the scapular skin flap closely resembles the texture and sometimes the color of the facial skin. The vascular pedicle can be dissected to the appropriate length and diameter to match the recipient vessels. Additional flaps can be carried on a single arterial and venous anastomosis, except in the cases of anatomical variations. The soft tissue element can be spatially oriented independently of each bone or the bone, enabling coverage of complex composite defects. Primary closure of the large skin flaps is possible, providing more skin than other osteocutaneous flaps. Limited morbidity with the minimal loss of the shoulder function if no preoperative limitation exists. The vascular pedicle is reliable even in the patients with diabetes as well as in atherosclerosis patients. So some of the limitations that we'll talk about here are some authors have described the flap harvest in a modified semi-lateral position to avoid the re-draping. मतलब we have to change the position of the patient. Two team approach is obviously not possible. Like it is possible in fibula, like one team can work at the head and neck end, and another one can work at the lower end, at the leg end. But here in scapular, it is not at all possible because we have to make the patient in the semilateral position to harvest this flap. Revascularization of the flap can only be performed after the donor site closure, as well as we have to close the donor site also to revascularize the flap. If undue tension is present at the closure, the donor site scar may be widened. However, it's very less. The skin grafting becomes necessary. This is inherently unfavorable site. Dissection of the circumflex scapular artery pedicle through the triangular space can be tedious and it consumes a lot of time. Because of the sensory branches from the third and the fifth intercostal nerves, which are divided during the elevation of the flap, primary sensory innervation is not possible. Bone stock may be limited in women, precluding the dental rehabilitation. So now we'll talk about the radial forearm flap. Pedicle, it is based on the radial artery with the vena comitans, and we can reconstruct the defects of shorter defects and defects that are straight line and less than 10 centimeter. Tissue, it includes the faciocutaneous, as faciocutaneous also. Course of the vessels is along the brachioradialis muscle as the leading structure. Dimension is 8 into 20 centimeter, and extensions and combination can be combined with the strip of brachioradialis and palmaris longer tendon, a bony segment of the radius or the second proximal skin island based on perforator vessels. So this is the anatomy. Radial artery, it is based on radial artery with two venae comitants. The length of the arc of rotation is up to 15 centimeter. Diameter is 3 to 4 mm in artery, and for veins it is 3 to 5 mm. Nerve is antebrachial cutaneous nerve. The bone that is carried by this flap is 1/3 of the cross section of the distal anterolateral radius. This is the anterolateral radius, and we only take the 1/3. The skin of the anterolateral forearm receives a significant blood supply from the radial artery, and it is preferably safe to raise a septal-based skin flap anywhere along the course of the radial artery. In this way, two skin islands may be raised, one for the proximal and one for the distal end, to facilitate the reconstruction for the through and through defects. This we are mainly talking about the faciocutaneous slabs. The cross section of the distal forearm in the osteocutaneous slab, the cross section of the distal forearm showing the disposition of the radial artery with respect to the vascular septum, flexor pollicis longus, and osteotomy. So 1/3 of the radial cross section is taken with an osteotomy. The skin pedal is situated over the dorsoradial aspect of the wrist to include the cephalic vein too. This improves the vessel access in the neck, but it is admittedly detrimental to the post-operative cosmetic appearance of the wrist. It looks very bad. Muscular attachments of the left anterior radius as well as the ulnar with respect to the radial bone graft are seen in second picture. The osteotomy is boat shaped to avoid the cross-cutting corners and excessive deepening. It is like a boat shaped. So what are the indications? It generally carries a two separate skin paddles which allow the reconstruct of the full thickness defect. Skin flap is generally thin, supple, and with reinnervation, which is capable of sensation approaching that in the normal mouth, which enhances the oral continence and may improve the speech, mastication, as well as the swallowing. And sometimes there is no drooling of the saliva too. This flap is used for the reconstruction of the thin bone. For example, the ascending ramus of the mandible and alveolar arches. And if we'll talk about the maxilla, so in orbital rim for zygomatic arches, and it also provides the mucosal replacement too. The segmental supply of the radial bone by the artery allow it to osteotomize once or twice for accurate contouring in the symphysis as well as the parasymphysial region. Mainly this radial flap we use in the straight defects, for example, for the body defects. The lateral segments of the body may be handled as a straight shot using the radial bone as the biocompatible reconstruction plate. So vascular pedicle is long. This is the advantage with the large caliber. So arthrosclerosis is rare and can be used as a flow-through flap when used as a free flap. Large flap can be raised as a multi-island flap with strips of de-epithelialized subcutaneous tissue and fascia between the skin islands. Many shapes are possible, usually thin and pliable it is, and it can be used in the obese patients too. It can be combined with the extensions or second skin island based on the perforated strips of the tendons and bony segments of the radius. Donor and the recipient sites can be dissected simultaneously, like one can work at the donor site and one can work at the recipient site. This flap is especially useful for low volume, for example, 2 to 10 centimeter of defects. So what are the disadvantages? The donor site morbidity. We have to put a skin graft and sometimes there may be a chances of failure. Very conspicuous donor site with potential impairment of the tendon function, especially in the women. Graft uptake can impaired distally. Sacrifice of the major forearm artery and because of the procedure is not intended for use around the mentum. Like for symphysis menti, the curving of the bone is needed. So generally we don't use it for the symphysis menti region. Symphysis region, so we usually use it for the either for the ramus or for the body region. So next is iliac crest flap. Iliac crest flap, the pedicle is deep circumflex iliac artery. It is osteo or osteocutaneous free flap. The modification of the original flap that uses only the medial wall of the iliac crest has contributed a major advantage, now allowing the bone flap to fill the defect precisely, thus refining its bony component and reducing the morbidity. So here, this is the ilium bone, and this is the muscle that we used to take along the skin and the subcutaneous. This internal oblique muscle is wrapped around the mandible, around the ilium of the lateral surface of the ilium to make the floor of the mouth. Sometimes it is used in the soft tissue defect like the floor of the mouth. So iliac crest osteocutaneous flap, it supplies bone with the height comparable to that of the native dentate mandible, which improves oral competence by supporting the lower lip. The harvested bone is primarily cancellous bone and is an excellent substrate for implantation due to its substantial height and thickness. Opening osteotomies performed in the iliac bone allow reliable construction of the anterior mandibular defects. The hemimandibular can be recreated from the ipsilateral ilium along the anterior superior iliac spine to restore the mandibular angle. By including the ascending branch of the deep circumflex iliac artery, the internal oblique muscle can be harvested and used for intraoral mucosal defects, as we have seen in this picture. Additional DCIA flap was used in any defects of the mandibular existed, from the condyle to the parasymphysis region. Even defects that cross the mentum also could be reconstructed, and the graft up to the 16 centimeter could be harvested along the crest. The DCIA osseous or osteocutaneous flap is suited for reconstruction of the ramus angle as well as the body region of the mandible. When osteocutaneous flap is involved, defects of the mucosa and the extraoral skin can be replaced by using the large skin pedicle. If the soft tissue defect is relatively large, an accessory flap for mucosal as well as for the skin coverage may be required, or skin coverage may be required. The medial wall of the this free flap can be taken with the bone along with the myo-osseous or even the osteocutaneous flap, thus providing the oral lining that we have seen in that picture. The medial wall has become the flap of choice for segmental mandibular defects. So what are the advantages? Advantages of using the medial wall, we can uh, significantly less donor site morbidities there, such as pain, hernia, deformity, and gait disturbances. The medial cortex is thinner and provides the flap that is less bulky, provides good contour to the mandible, and is more cosmetically acceptable as compared to the fibula because it is a straight bone. Variations include the use of the internal iliac muscle for soft tissue coverage, allowing the muscles to rotate it through any arc for coverage of any defect, and provision of thin pliable tissue. This flap allows the soft tissue coverage with reconstruction of almost any mandibular defect except the defects that cross the mentum, matlab, symphysis menti. The thickness of the iliac crest allows the placement of integrated implants too. So what are the disadvantages? The donor site we generally used to see, and the issue related to the donor site include challenges of restoring the abdominal wall to prevent the hernia formation, as well as the rehabilitation requiring to achieve the normal ambulation. So this I have made a small summary of these flaps, in which we'll discuss the arterial supply of these flaps, venous outflow of these flaps, nerve supply of these flaps, tissue what we used to take, advantages and minor disadvantages. So we'll talk about the fibula. It is based on peroneal vessels. Venous commitance is the venous outflow. Nerve generally we don't take, and sometimes if we take it is lateral cutaneous nerve. Tissues that we use are skin, uh, skin, fascia, bone, as well as the this sensate flap. This nerve also we used to take. It has excellent bone stock. It is sensate, and two team can approach at a single time. One at the head neck end and one at the leg end. The donor and the recipient side both. Disadvantages are limited mobility of the skin from the bone. So it is very sticked to the bone. And another one is single skin pedicle. In the radial flap, the arterial supply is radial. Venous is distal cephalic vein or the vena comitans. Medial and the lateral brachial cutaneous nerve. Sometimes we use bone. We used to take in less number of 40 percentage. Mostly we use it as a facial cutaneous flap. It is a so what are the advantages? It is a thin pliable skin flap. Two teams can harvest at a single time, so this will reduce the time of surgery. Long pedicle is achieved. We can use a sensate flap with the help of the medial and the lateral brachial cutaneous nerve. It has a potential for tubing. It can be made into a tubular structure, and it is also used for the through and through defect. So what are the disadvantages? Donor side scar is there. Sensory deficit, range of motion because we used to take the bone. So wrist movements hampered, hampers the strength of this bone. Sometimes fracture of the bone can also occur and limited bone. Only the 10 centimeter or short segments is reconstructed in the mandible. So moving on to the scapula free flap, it is based on the circumflex scapular artery with the vena comitans. No nerve, skin, subcutaneous tissue, fascia, bone, muscle we can take. Multiple flap options from single pedicle has been taken with excellent 3D in setting and rare peripheral vascular disease we usually see. The main disadvantage is positioning of the patient, that we have to position the patient in the lateral position and the closing. Before anastomosing, we have to close the donor site. So these are the disadvantages. So moving on to the iliac flap, arterial supply is DCIA and venous is superficial inferior epigastric. Nerve, no nerve. And tissue is bone we used to include. And what are the advantages? Large bone stock with the skin and the muscle. And it is difficult to harvest and donor side pain is there. So now we'll talk about the survival of the flap. As we have compared all these flaps, so here we'll talk about some of the survival of the flap based on their functional stability. An osseous flap used for the reconstruction of the oromandibular defect should be reliable, functionally, cosmetically acceptable in terms of the mandibular length, width, and thickness. So, in the article, 22 studies have been taken in the total of, it is a meta-analysis in which 1,513 patients were taken, in which all the four flaps were compared, fibula along with the iliac, scapular, and radial flap. With the survival rate, if we'll compare the survival rates of these four, so it was 94% in fibula, 93% in iliac, 97% in scapula, and in radial it was 95.95%. That means almost 96%. So based on the survival rates, this radial is fine. In the deep circumflex iliac artery flap, it offers a distinct advantage over the single barrel fibular technique. Sometimes we use a single barrel fibular technique or the double barrel technique. So if we are using the single barrel technique, in that iliac is better than fibula, because it provides the adequate bone quality and the quantity for the replacement of dental implants that mimics the vertical height of the native mandible. Most importantly, the curved shape of the iliac crest that suits the parabolic shape of the mandible, especially the angle region of the mandible. So, Leverte et al. Reported 100% survival of 12 implants in scapular flap, whereas it was 83% in 64 implants in fibula flap, 76% survival of 25 implants in iliac, and 80% survival of 15 implants in radial flap. Recently, the scapular flap has regained the wide popularity for bone reconstruction of the head and the neck region due to the good bone stock for the reconstruction of the lateral mandibular defect, great mobility of the skin pedal, whereas we have a disadvantage in fibula because that skin is so much adhere to the bone. The option of simultaneous tumor resection and flap harvest with the 100% survival rate. Not only the flap survival, we should not only see only for the flap survival rate, instead we should also see the surgeon's preference also, the patient age, what is the age of the patient की medical condition क्या है, along with the defect size, what is the defect size, if the defect size is small, so we'll go for the radial, if the defect size is large, we'll go for the fibula, if the defect size is at the angulation, so we'll defect the location of the defect also we used to see. So we'll go for the iliac or for matching the contour of the mandible. So location of the defects are also seen, and indentation of the dental implant rehabilitation is also seen. So we'll talk about the dental rehabilitation with the osteo-integrated implants. That is the most important part for any patient to account for functional as well as the aesthetic rehabilitation. So dental rehabilitation supports with the endosteal implant help to restore the functional mastication, facial aesthetic, and supports the lower lip. The ability to restore functional mastication is very dependent on the status of native or reconstructed tongue with respect to its ability to manipulate the food between the opposing incisal surfaces. Requirement of implant. Patients we consider for implant should demonstrate good oral hygiene, have a reasonable interincisal opening, and a favorable prognosis for survival and anticipated favorable post-operative swallowing function. So two-stage implant placement is there. First of all, fixation placement followed by the exposure of the implant, and next is placement of the transmucosal attachment. Following placement, the implant is allowed to integrate in 4 months in the mandible and 6 months for maxillary implants. The transmucosal attachment is then placed, and 2 weeks later the denture is attached and load bearing follows. Vascularized bone flaps for mandibular reconstruction have facilitated the use of primary implant placement. So what are the advantages? Implanting at the time of, at the time of surgery, uh, both can occur at the same time. So it reduces the time of the surgery. So primary implantation does not affect the external beam treatment, planned or delayed treatment. It also optimizes the time for integration to occur prior to the onset of damaging effects of the radiation on the bone. Conventional implant stability in determining both clinically and radiographically. An implant is considered a success if it is immobile, does not cause any pain with the manipulation, and demonstrate no peri-implant radiolucency on radiographic examination. In addition, there should be peri-implant vertical bone loss less than 0.2 mm per year after the first year from implantation. We reported 728 fixtures in 183 head and neck cancer patients with an overall survival rate of 95% and 88% of the patients who subsequently had radiation. So what are the persistent problems that we usually face with these dental implants? Problem of osteoradionecrosis is seen, and post-operative radiation therapy can cause osteoradionecrosis, loosening of the hardware. Radiation therapy also causes the tissue fibrosis. Sometimes xerostomia can occur, loss of the taste, trismus, and the damaging effects of the radiation also cause continued problems for the survival rate of the osteo-integrated implants. And implant failure can be significant problem even in the patients who have undergone optimal approach with primary placement and radiation at 6 weeks following surgery. So conclusion came in onto the conclusion. Reconstruction of the segmental mandibular defects after ablative surgery is best accomplished using the free tissue transfer to restore the mandibular continuity and function. Establishing the occlusion as well as and optimizing the tongue mobility, which are the important factors for post-operative oral function. Persistent problems in uh, oral mandibular reconstruction relate to the effects of radiation treatment on the native tissue and include the xerostomia, dysgeusia, loss of taste, and osteoradionosis and trismus. These problems continue in oral cancer patients despite the significant advances that allow a far more complete functional restoration than that could be accomplished 2 decades ago. So these are my references.
Tell me, if you have a mandibular canal involvement, can you hear
Yes,
me?
sir.
If you have a mandibular canal involvement, what will be your margin? Will you do a wide excision or you will excise the whole canal? Means your margin will be at the ramus of the mandible or just adequate margin of 1 centimeter from the site where it's involved.
No, sir. We'll take out the whole ramus, sir, because it involving the mandibular canal.
What is the other major problem we face in while planning the prefibular flap?
Sir, other problems.
I mean, where we don't end up doing the flap itself, or what are when we cannot do what are uh, under what condition we cannot do a free fibular flap.
Sir, sometimes we usually see the vascular anomaly.
What is the anomaly and how do you identify it?
Sir, peronia magnus is seen.
Right. So how do you identify it?
Sir, we usually go for the angio of
So
the
what do you see
both
in
of
that?
the legs.
What do you see in the angio? You should actually see the CT and tell yourself that whether it's peronia magna or not there. What do you mean by peronia magna? See, if there is peronia magna, you see a single large vessel in the leg on CT
Yes, sir.
scan, a single large
Yes,
central vessel.
yes,
As
sir.
opposed to anatomy, where will you see a vessel which divides into three other vessels. So you'll see
Yes,
three white dots
yes,
in a
sir.
in an actual scan of leg. When
Yes,
it's
sir.
anatomy, and you'll only see one big white dot when there is peronia magna.
So, which are the arteries which get uh, hypoplastic in peronia magna? Which
Sir,
two arteries are hypoplastic?
anterior and posterior tibial arteries, sir. That
Anterior and
are
posterior tibial
found.
artery.
What is reverse mandibulectomy?
The reverse mandibulectomy is done usually in the inferior border of the mandible when the lymph nodes is adhered to the lower surface of the mandible. But it is not done so much because the inferior border of the mandible doesn't take the masticatory forces of the masticatory forces and it may lead to the fracture of the mandible. So that's why whenever we used to do the marginal mandibulectomy at the upper surface, so we used to leave the 1 centimeter bone at the lower end of the mandible.
So, if you do a reverse mandibulectomy and take out the
Yes,
inferior
sir.
border,
We can put the plates, we can put the reconstruction plates over there,
yes,
or
whenever
we
you have to
can,
do it, you have to reinforce. Don't say you
yes,
can't do it and
we
you
can
should.
put mesh.
You can do it and
Okay.
provide a reinforcement.
Oh. And titanium mesh also we can place.
Yes, you can always do a titanium mesh also. So anything to strengthen the remaining mandible. Will you do a marginal mandibulectomy in patient with trismus?
Will you do a marginal mandibulectomy in a patient with?
Trismus.
Then how will you take care of the mouth opening? See, by doing a segmental, you're improving the mouth opening.
Yes, sir.
So I agree. I mean, you can do technically you can do a marginal mandibulectomy, but how will you take care of the mouth opening? Patient will still complain to you that he cannot open his mouth.
So we can do the intraoral coronoidectomy. By intraoral incision, we can go for intraoral coronoidectomy. So we can release the temporalis.
The cause of
So will that?
trismus in most of the patient.
What is the mechanism? Why does
What is the cause?
patient?
What are the various causes of trismus in oral cavity cancers?
Sir, in oral cavity cancers, due to the involvement of the muscles of mastication, sir, matlab masticator muscle, because of the involvement of the pterygoid muscle, because of the involvement of the temporalis muscle, sir.
Same
These
thing
are
only. Involvement of infratemporal force. T4A disease. What else?
Say when there are no involvement of masticatory muscles, patient still has a trismus, then
okay. Because of fibrotic bands, sir, because of OSMF.
because of OSMF. So if you have to do a marginal mandibulectomy, what you have to do?
We have to, for marginal mandibulectomy, we have to increase the mouth opening of the patient by giving the buccal mucosal vertical, this horizontal cuts we can give from commissure to posterior region of the buccal mucosa, and we can reconstruct, we can divide these fibrotic bands, and later on we can construct it, we can improve the mouth opening of the patient, and later on we can construct it with the buccal pad of the fat or with the collagen. Or
In case the trismus is because of involvement of masticatory muscle, the moment you take the tumor out, the trismus is relieved.
yes,
But
sir,
if
this
it is
also.
because of submucous fibrosis, you have to
Yes.
assess the other buccal mucosa and release the bands on the other side. This side will
Oh,
release once you
okay.
excise the buccal mucosa or the
Yes.
mandibular area. So you have to
Yes, yes.
release on both the sides to release the trismus.
Oh.
Why it is important to release the trismus?
To allow the patient to eat, sir, properly, and to swallow and to take the food inside the mouth, and speak properly. Sometimes it is to improve the quality of life, basically, sir. And and for dental cleaning also, for dental cleaning also, sir, oral cleaning. It is very much important. And if Christmas occurs, there is uh, this tooth that sometimes they used to erupt in a different way, and this may lead to the interocclusion, dearrangement of the interocclusion relationship.
Sir, actually, I had a small doubt, sir. Sir, in your paper, which was mentioned in the seminar, the PNI and inferior alveolar nerve involvement precluded the mandibular conservation. Like,
Yes.
if we have attempted a marginal mandibulectomy and in post-op, if we get a alveolar nerve or gross extramural PNI positive, like,
Yeah.
how do we go about in adjoint? Like, should we consider for segmental or should we leave or?
That is the question that Dr. Tarun asked in the first place. If there is a involvement along the nerve, that means
Yes, sir.
involvement of the canal, can you still do a marginal mandibulectomy or not? You
Uh,
can still do a marginal mandibulectomy, including the canal. See, the main emphasis is to get a negative margin.
Yes, sir.
How many different margins are there on your mm, oral cavity specimen?
So all the mucosal margins, sir, and all the direction and all the depth margin. It's the tumor base.
Have basically three margins. You have mucosal margins, then you have soft tissue margin, and you have bony margins.
Only margin.
Yes, yes.
So all the three margins has to be negative. That is the requirement. Your mucosal margin should be negative, your soft tissue margin should be negative, and your bony margin should be negative. So if you can achieve a negative margin, marginal mandibulectomy, you can go ahead. Provided you have enough remaining mandible to give it strength so that fracture doesn't occur.
Sir, one more question, sir. Like, in clinical practice, sir, how often oblique marginal mandibulectomy is practiced, sir? Like in floor of mouth
Uh,
disease, like how often?
you see the paper from Jatin Shah's paper. Now, all the papers which will be coming from the western side, you will see more of oblique marginal mandibulectomy because they deal primarily with the tongue cancer,
Yes, sir.
while we deal primarily with the buccogingival cancers. So that is why
In
our
India,
marginal mandibulectomy is different from the margin mandibulectomy done for the tongue cancer is different from that done in the because the outer cortex need not be taken out there.
yes, sir. Yes, sir.
So you can just take out the inner cortex. But in a buccogingival sulcus, you have to take out if the involvement is of gingiva, you have to take out both sides. So that is the difference. So difference basically is on the location of the tumor rather than anything else.
Isn't marginal mandibulectomy advised in edentalous patients?
Why we don't do? Sir,
Yeah.
Mm.
because the residual ridges that is left, that is बहुत कम बच जाती है, बट वो एज के साथ रिजॉल्व होती है और वो कम बच जाती है, इसलिए सर फ्रैक्चर होने के चांसेस रहते हैं, so we usually go for segmental.
Length of the mandible is reduced, so chances
Right,
of fractures height कम होती है, chances of fracture are high.